Assalamu alaikum, IMANA community. It is Sister Amber here, IMANA Education Chair. We are back with another webinar this evening. And today we have a very special one. It's on oral health and how it affects overall health. And so this is a topic that, is very much needed, and one that, we as a general community, not just those in the medical profession, but just the general community, is important for us to not just promote to our patient community, but also for ourselves. So hopefully we'll get some really wonderful tips for ourselves and for our families. Our speaker tonight is the wonderful Dr. Umar Haque, and I just want to take a few minutes to share a little bit about him before I pass the mic over. Dr. Haque, he graduated from the University of Connecticut School of Dental Medicine. He has completed a general practice residency at the University of Illinois and University of Chicago. He's been practicing for over 20 years. He's also the author of the book Dental 101, the 101 factors you should know before going to the dentist. Dr. Haque has also taught at Midwestern University College of Dental Medicine. He has a plethora of curriculum and teaching certificates and that he has achieved over the years. And he is currently owns a private practice facility called Oakbrook Smiles in Oakbrook that has been in practice for over 20 years. So if you're in the Chicagoland area, check it out. And I'm going to go ahead and pass it off to Dr. Haque. Thank you so much for being with us tonight.
Thank you so much, Dr. Khan. Really appreciate the invitation and looking forward to sharing a little bit about the oral systemic connection and how dentists and physicians can work well together, in my humble opinion. So I'm going to kick it off, inshallah. So assalamu alaikum to everyone. Thank you for inviting me and giving me some of your time. I will tell you, first-hand experience during my career, I've seen so many different elements from the pediatric dental world to pediatricians, from oncology, radiology, cardiology, so many different aspects, internal medicine, just in general, family medicine, psychiatry, how many patients come in with dental phobia, regardless, sleep medicine, goodness, airway. We're going to get into a lot of that today. So just wanted to let you know that there are a lot of correlations between medicine and dentistry. And today, my goal is to, inshallah, take a closer look at how all these conditions that we manage can be deeply interconnected. So a couple of disclosures. I have no actual or potential conflict of interest in relation in this presentation. I have no financial relationships or commercial interests with any medical or dental companies. I do spend a lot of money on them because I have to buy supplies from them, but I do not receive any funds from them for this presentation at all. It's my team at Oakbrook Smiles. Got a great team. I love them. They're awesome. My wife works with me as well. She's my office manager. But a little intro into what we're diving into today, the concept of oral systemic connection, the idea that oral health and systemic health are not separate, but deeply interconnected. And I'll be presenting evidence on how oral infections and inflammation can impact diseases beyond the mouth, as well as benefits of dentists and physicians collaborating for better patient outcomes. As we know, back in our history, Ibn Sina, the author of the Canon of Medicine, he actually, in his book, The Canon, he wrote about dental instrumentation. And back in those days, there was no differentiation between medicine and dentistry. It was considered one and the same. It was considered part of medicine. It was considered part of the surgical interventions that they would take on. Here you can see a couple of pages from that book, The Canon, the original, that's been preserved. Some really cool pictures. Some of those instruments, I will tell you, hope you can see my mouse, but there are a few instruments in here. Like right here, this small blade right here looks a lot like our number 12 blade that I use today. Over here, there is an instrument on the side. This looks a lot like one of our periosteal elevators. It's unbelievable. We still use those today. So, oral systemic connection defined. Oral infections such as periodontal disease, they lead to chronic inflammation, specifically in the mouth here, which affects the body as a whole. bacteria from the mouth can enter the bloodstream, and they do, potentially impacting other organs and systems, triggering inflammation or even infection far beyond the oral cavity. Now, small warning, some of the photos and images you're about to see might be a bit disturbing, but you're all physicians, we're healthcare professionals, you can deal with it. Here you go. Periodontal disease, chronic inflammatory condition that primarily affects the soft and hard structures supporting the teeth. This is a severe case, obviously, but it also has a lot of decay. This kind of inflammation, not good for the body, honestly. We only have so many white blood cells. And if we have a chronic inflammatory condition going on, a lot of those white blood cells are diverted to the mouth instead of dealing with other elements that are going on in the body at all times. Let's go back to the beginning. It begins with plaque accumulation on the teeth, which, if it's not adequately managed, can lead to an inflammatory response in the gums known as gingivitis. If you look carefully around the gums, you will see some erythema, some redness around the gums, specifically around the margins. And a lot of that is due to this calculus buildup around teeth. Calculus, when it gets hardened, it doesn't come off that easily. It does not come off as easily as plaque does. Plaque can be brushed off or flossed off. Calculus needs a physical debridement to take it off. Gingivitis, left untreated, progresses to periodontitis, where bacteria cause the breakdown of the periodontal ligament. Now, the periodontal ligament, if you could imagine the tooth as a hole, the part of the tooth that's the root, which is in the bone, it's suspended to the bone. It's not actually fused. It's suspended to the bone by thousands and thousands of fibers that collectively are referred to as the periodontal ligament. And that is what holds our teeth in our alveolar bone. And there's alveolar bone both in the maxilla and in the mandible. The maxilla here on the upper jaw, mandible below. And when periodontitis starts and it starts to set in, that periodontal ligament breaks down and starts to break down and eventually does lead to tooth mobility and eventually potential tooth loss. As you can see here, a more advanced case, it also results in systemic issues. And research has highlighted its connections to cardiovascular disease, and we're going to go into a few studies, diabetes, and other systemic conditions likely due to chronic inflammatory burden and potential bacteremia. And in clinical practice, effective management relies on regular cleanings, patient education on oral hygiene, and in advanced cases, surgical intervention to restore periodontal health, and oftentimes, unfortunately, in cases like this, extractions where we're removing teeth. The American Association of Periodontology has shown that 75% of Americans have some form of periodontitis, the number one leading cause of tooth loss or edentulosum. Now, in this case, you can see severe bone loss around all of these mandibular anterior teeth, aggressive calculus accumulation and plaque. But also, if you notice, these teeth are really splayed. They're actually spread out. And that's due to so much bone loss that the occlusion or the bite is affecting the position of the teeth. As we know, muscles are stronger than bone, and muscles will push things. And in this case, this patient missing a lot of posterior teeth ends up using the anterior teeth to masticate. And in turn, it breaks them down. They're not made for chewing and really masticating. They're meant for cutting. That's what our incisors are for. So periodontal disease, particularly in its advanced stages, can facilitate bacterial invasion into the bloodstream, leading to systemic health impacts, including cardiovascular conditions. When periodontal pathogens enter the bloodstream, they potentially adhere to damaged or inflamed heart valves, increasing the risk of subacute bacterial endocarditis in susceptible patients. Now, a lot of our patients that have tetralogy of Fallot or have had a history of rheumatic fever or have an artificial heart valve, we have to give them antibiotics before dental treatment because we don't want subacute bacterial endocarditis. So we call it SBE prophylaxis, oftentimes with 2 grams of amoxicillin or 600 milligrams of Clinda. But these are really important situations to keep in mind with your patients if they have any of those congenital heart issues. So one of these things that happens is these pathogens trigger an inflammatory response, producing cytokines and other pro-inflammatory markers that contribute to the endothelial dysfunction and plaque formation in arteries. And that systemic inflammation and bacterial presence are linked to atherosclerosis progression, and that elevates cardiovascular risk factors like arterial stiffness, blood pressure increase. The link between chronic periodontal inflammation and cardiovascular health underscores the importance of collaborative management in reducing systemic inflammatory burden for at-risk patients. There was a study in JAMA by Spar et al., and they followed 789 subjects, and they looked at periodontal pathogens, specifically A. actinomycetes comitans, T. fluorescentis, Porphyromonas gingivalis, Prevotella intermedia, and Treponema denticola. And they used DNA-DNA hybridization. And what they were doing was assessing both the periodontal pathogen burden as well as their presence of coronary heart disease. And both in terms of the association between that pathogen burden, specifically A. actinomycetes comitans in the periodontal pockets, and the presence of coronary heart disease was significant. It was statistically significant, and they had a p-value of less than 0.001. And their findings did suggest an association between periodontitis and the presence of coronary heart disease. If you want the actual PDF of the article, if you use your phone or take a screenshot, that QR code will actually take you straight to the PDF of this full article. So here's a look at how these pathways work. When bacteria from oral infections enter the bloodstream, they don't stay in the mouth. They can reach the heart, lungs, brains, and even joints. And with joints, we have to be really careful, especially with patients that have had artificial joints like knees and hips. Especially recently, if they've had those done, we don't want to do any major dental surgeries right away without antibiotic prophylaxis, or else we can get infections to those joints. And this contributes to an inflammatory response in those areas, showing us that an oral issue can have systemic consequences. There's compelling evidence linking gum disease with cardiovascular health, and research has shown that people with periodontal disease have a higher risk of heart attack and stroke. That inflammation caused by periodontal disease can contribute to atherosclerosis, where plaque builds up in arteries. It's a powerful reminder that we as dentists do have an impact on being able to coordinate care with the physicians as well. Oral health is crucial for patients with diabetes. It's a two-way relationship. It's not a cause and effect, but uncontrolled diabetes can worsen gum disease, and in turn, uncontrolled gum disease can make blood sugar harder to control. That chronic inflammation from periodontal disease increases insulin resistance and creates a vicious cycle. This connection means that by controlling oral health, we can support better diabetic outcomes. Oral health even plays a role in pregnancy outcomes. Pregnant women oftentimes get more inflammatory responses in their mouth because of the change in hormones, because of the fact that the mom is now trying to take care of the baby that's developing. Pregnant women with gum disease have a higher risk of complications, such as preterm birth and low birth weight. Inflammatory markers and bacteria in the mouth can enter the bloodstream, and it does impact fetal development. So good oral care is an important preventive measure for expectant mothers. Another area that we see a risk is in respiratory infections. Bacteria from the mouth can be inhaled into the lungs, which can lead to infections like pneumonia, particularly in vulnerable populations like the elderly. A simple dental checkup is a really important preventive step here. We talked about orthopedic joint replacements, antibiotic prophylaxis, oftentimes recommended, although the American Association of Orthopedics and the American Dental Association sort of go back and forth because of the fact that they don't want to create scenarios where patients have resistance to certain antibiotics, or bacteria, don't have resistance to certain antibiotics. Congenital heart conditions, SBE prophylaxis, we spoke about that earlier. A couple other things I wanted to discuss was squamous cell carcinoma. That's one of the things that we do screen our patients for, and almost all dentists do as well. It is the most common type of oral cancer and accounts for 90% of the cases. A few other kinds of oral cancers that we see: verrucous carcinoma, a rare low-grade cancer that affects the gums and the cheeks. Minor salivary gland cancers, they can start in the glands and the linings of the mouth and throat. Lymphomas, cancers that can start in the tonsils and the base of the tongue. Oral malignant melanoma, a less common type of oral cancer that starts in melanocytes, a cell that gives skin its color. Adenocarcinomas, they develop in the salivary glands. And basal cell carcinomas, a type of skin cancer that affects the lip, nose, scalp, and cheeks. Another thing that we also look at as dentists when we examine our patients is the airway. We have our patients open wide and say, for a reason, because we're looking at the back of the throat. That airway has a big impact on the Mallampati score, obviously, but it also has an impact on whether or not they clench or grind when they sleep. When someone has a really small airway, they oftentimes will thrust their tongue forward when they sleep and into their teeth. So in turn, we end up clenching and grinding in those scenarios, but we still usually snore, especially if it's a Mallampati 3 or 4. And we're going to go into that further, but it's a really great screening tool for us to help refer a patient to get a sleep study done with their physician or their respiratory specialist. And the last thing that really is one of the biggest factors in terms of emergency care in dentistry is space infections. Just under the mandible, there's an area called the submandibular space, and that goes over to the lateral pharyngeal space. If that infection spreads there, it can become life-threatening. And just up until the early 1900s, it was space infections, dental infections, were among the leading causes of death. Thank goodness, no longer. Alhamdulillah. Emerging research is also connecting oral health to cognitive decline. And one study found that bacteria typically involved in gum disease, specifically P. gingivalis, has been found in the brain of Alzheimer's patients. It's still emerging right now, and it's still not fully proven yet, but it highlights the wide-reaching effects of oral health and overall well-being, even in our cognitive health. Little Dental 101, primary dentition. We start off with 20 deciduous teeth, also known as primary teeth. Some people call them milk teeth. But these teeth right here, there's usually 4 molars on the maxilla, 4 molars on the mandible, and it goes straight to canines and anterior incisors. 4 incisors on the upper, 4 incisors on the lower. So it's 4, 2, 4. 4 incisors, 2 canines, and 4 molars. So that's why there's 10 on the upper, and it's the exact same thing on the lower, just the lower teeth are a little smaller. Here's a picture of what it sort of looks like. Now, you'll oftentimes see gaps between the teeth on primary teeth. And some parents come in, they're like, oh my God, my kid's got spaces. It's actually a good thing because our adult teeth are a lot bigger than our primary teeth. I don't really see too many kids in my practice, but pediatric dentistry is a specialty of its own as well. And oftentimes we work hand in hand with pediatricians to get their care taken care of properly, and obviously school forms. So moving forward, there's an eruption process. The primary teeth exfoliate or come out, and then the adult teeth start coming in. Oftentimes those adult teeth will come in posterior or medial to those primary teeth. Posterior in the front teeth, medially on the posterior teeth. So when those teeth are coming in, they come in sort of from behind almost and push the baby tooth out slowly. Or sometimes they come in straight from below and push them right up. So oftentimes when our children are going through pain, they're teething. And teething is no fun, especially the first time around. But even the second time around, it's not great either. Sometimes they'll get fevers because of the bacteria that enter the bloodstream from that process of eruption. Because as the tooth erupts, there's pockets right where the enamel and the soft tissues meet that can't be cleaned anymore. And so bacteria enter there through our saliva and into our bloodstream, thus causing fevers. Now, with our adult teeth, we have 32 teeth. We have 16 maxillary, 16 mandibular teeth. In America, our numbering system starts from the maxillary right to the maxillary left, mandibular left to the mandibular right. Don't ask me why the rest of the world does it differently, but we have 1 through 16 on the upper, 17 through 32 on the lower. If you ever are wondering about the eruption patterns of teeth, if you just go to Google and type in dental eruption pattern, you'll get this chart. as well. And if you're ever wondering what tooth you're looking at, you can look this up as well. All right. So, little dental 101, tooth anatomy. We've got a few things here. Got the part of the tooth that we can see is called the crown of the tooth, but also can be a little confusing because when we do a certain procedure, it's called a crown as well. Under our gums, there's an area called the roots of our teeth. That has inside of it the living part, which is the pulp. So when people say root canal, what is done is basically the extirpation or the removal of the pulp of the tooth. The enamel is mostly found in the crown of the tooth. Underneath the enamel is a thing called dentin, and the tertiary layer within is the pulp. And last thing, around the periphery is the periodontal ligament. All right. Dental 101, pathology. Caries, commonly known as tooth decay or cavities, is a bacterial-driven process that results in the demineralization and destruction of tooth structure. It occurs when oral bacteria metabolize sugars from food and beverages, specifically strep mutans most of the time, producing acids as a byproduct. And those acids erode the tooth's enamel, and if left untreated, can progress through the dentin, reaching the pulp, and that's what causes pain and causes infection and oftentimes tooth loss. So preventing caries is honestly paramount. So the way to prevent it is good oral hygiene practices, regular dental checkups, dietary management, specifically sugars and acid. So a lot of people say, oh, Diet Coke, it has no sugar. Yeah, but it's super acidic. Be careful. Chase it with water. And the last thing, fluoride. That strengthens the enamel and resists acid attack. A lot of people are anti-fluoride. Xylitol also works. And oftentimes caries and periodontitis are related to xerostomia or dry mouth. And dry mouth, how does that affect medicine? Well, when a lot of my patients, especially my elderly patients that are on a laundry list of medications, a lot of the side effects of many medications is xerostomia. And when you have dry mouth, you have less internal lavage. You have less self-cleansing that's going on all the time. You know, our saliva is constantly flowing, right? And we swallow 2 liters of saliva a day. It's disgusting, but it's true. And it gets recycled, right? Some of that saliva is super important to help cleaning plaque, food particles, other calcification that develops on our teeth from our own saliva. It's important. So when we have less saliva, what do we get? We unfortunately get increased bacterial load on our teeth and our gums, and we get increased cavities and gum disease. Most common pathology in our mouths, unfortunately, is periodontal disease. And we talked about it earlier. Here's a picture of untreated periodontal disease. And here's a picture of treated periodontal disease. Yes, you've lost bone, but now these teeth are clean. These roots are clean. And when you get clean surfaces, you can preserve teeth. This patient was told by another dentist they wanted to take everything out and they wanted to put in a few implants. And I asked the patient, do you want to take your teeth out? Do you want to save your teeth? The patient said, yeah, I want to save my teeth. I don't want implants right now. And so we talked to him, we got through it, cleaned them up, and we got patients to save most of their teeth. We did have to take a few. Regardless, patients, you know, what Allah gave us is the best, all right? And if we can save it, let's do it. Another common finding that we find in our patients is what's called bruxism. Bruxism is a scenario where we actually clench our teeth together and really just catatonic contraction of all of our muscles of mastication. And it does break down enamel. You can see in this patient, the edges of the incisors really breaking down. This patient was given one veneer. I don't know why, but this is how the patient presented. And we did clean this patient up. And we did eventually do some veneers, but regardless, another thing that happens is grinding. Grinding is more, not just catatonic contraction, but more side to side and forward and back. And that wears down all of the cusps of the teeth. All the posterior teeth really worn down. And that's where you can tell that someone's grinding as well. It's not just the anterior, it's also the posterior teeth. Bruxism usually is more so the anterior teeth that break down. The muscles of mastication, TMD or TMJ disorder, right? One of the things that causes TMJ disorder is that catatonic contraction. When patients have, sometimes it's habit-based, sometimes it's sadly due to us, dentists. If we do some poor dentistry, patient's got a bite that's off. Now the patient all night is grinding their teeth to try and wear down that spot that's off. And the muscles of mastication, temporalis, masseters, lateral and medial pterygoids, those four in particular, the major ones, when those muscles are overused, they beat up the TMJ. And there was a great article in the New England Journal of Medicine by Scrivani et al. This was in 2009. And also, I'm going to show you a QR code in a second. You can look that up. Talks about how temporomandibular disorders remain a frequent cause of visits to primary care physicians, internists, and pediatricians. And he talked about myofascial pain, medications including NSAIDs, muscle relaxants, tricyclic antidepressants to treat it. And he also discusses oral appliances and their effectiveness for specific types of TMJ disorders. Now, some of those oral appliances sometimes are night guards, sometimes they're basically these things called deprogrammers that help prevent those muscles from going into that catatonic contraction. And so that was in the New England Journal of Medicine not too long ago. It was a study out of Tufts and Harvard. And again, you can get the entire PDF of this article if you just use that QR code. So it's by Scrivani. All right, on a CT. So in dentistry, a lot of times we now take cone beam CT scans and we can look at a lot of things in 3D. This is a cone beam of a patient that does have pretty significant TMD, but this is intracapsular, meaning in the capsule of the TMJ. And if you take a look at these cross-sectional views of the TMJ, normally what we want to see is what we see on the patient's right side, a little bit more rounded. But when we see this scenario, if you ever remember the old porters with the bald eagle's head in profile view, that's what you sort of see here, this bird beaking on the corner of the TMJ and the anterior aspect of the TMJ condylar head. So right here, what you're seeing is the mandible articulating with the glenoid fossa. And when that bone-on-bone situation is occurring, it's oftentimes from clenching and grinding. And unfortunately, the disc, the condylar disc, has been displaced most times. Going back to the Mallampati score, we were talking about this earlier in terms of sleep apnea. It's a simple screening tool that we use every time we take a look at our patients. And when we see a class 3 or 4, we look at the borders of the tongue. If we see scalloping on the borders of the tongue, that means that they are tongue thrusting when they're sleeping, and guaranteed they're clenching and grinding as well, or clenching or grinding. When they're clenching and grinding, they're breaking down teeth. So how do we help deal with this? This is where we refer the patient to our physicians, to their physician, and say, hey, get a sleep test, please. Talk to your physician about your airway. Talk to them about how your dentist's concerned that you may be snoring, you may have sleep apnea. And so it's a wonderful referral tool for us to work with our fellow physicians. There was an article from Japan by Ishiyama called Morning Headaches Caused by Obstructive Sleep Apnea, and it was misdiagnosed as TMJ disorder, or TMD. And in patients experiencing TMD symptoms and morning headaches, TMDs should not be presumed as the sole cause. Dentists really need to discuss the likelihood of sleep disorders during consultations. And if sleep disorders are suspected, the possibility of obstructive sleep apnea, OSA, really should be considered, and sleep tests need to be conducted when necessary. So this is actually an article literally just a couple of months ago out of Japan, August of 2024, just a few weeks ago, actually. Really cool study. Space infections, quite dangerous. This was the thing I was telling you about, how in early 1900s, this is what killed people. So these dental infections, they spread from the submandibular space to the lateral pharyngeal space and sometimes retropharyngeal space due to the anatomic proximity and connections and the loose connective tissue boundaries between those areas. And that can lead to serious complications like airway obstruction if not treated promptly. So today, we put them on aggressive antibiotics. We oftentimes will refer them straight to the oral surgeon or to the hospital because they need to be drained and they need to be put on IV antibiotics. Progression of caries. Decay goes from basically the biting surface of the tooth in this case to further into, so in the first picture all the way to the left, you'll see enamel is broken down. Second picture, you see the decay is going into the dentin, which is the secondary layer. In the third picture, you see it now the decay has gone into the pulp chamber. And in the final picture here, you see it's now spread down into the bone. And it creates this thing called an abscess at the apex of the roots, at the ends of the roots. When that infection spreads to the ends of the roots, it now is systemic. It's no longer just localized to the tooth. It has now spread. But it is bacterial, so it can be managed. Antibiotics will help manage it for some time, but the second the antibiotic's over, that bacterial direction still flows. We have to do something to manage this. Either we extract the tooth or we'll do a root canal buildup in crown. So the impact of poor oral health on the well-being. Beyond specific diseases, poor oral health impacts general well-being. Problems like tooth pain and missing teeth can make it difficult for patients to eat well, impacting nutrition and digestive health. And don't forget the psychological side. Poor oral health has a huge impact on people's self-confidence, and it leads to social withdrawal and sometimes even depression. And overall health, as we talked about at length, to chronic inflammation and the effect that it has systemically. So how do we deal with this? Early detection, prevention. One of the most powerful tools we have is prevention. Regular dental checkups can catch oral issues early, preventing them from escalating and affecting systemic health. And often we as dentists can be the first to notice signs of systemic conditions like dry mouth, gum inflammation in a diabetic patient, long before symptoms appear elsewhere. And so monitoring, really important for our regular routine patients, making sure nothing else has changed in their health history. It's one of the things we always ask our patients is, have you had any changes to your medical health or your medical history? And sometimes patients are like, wow, why do you care? Because it has a big impact on oral health as well. So one of the things that we look at, some of the things that we can look at are diabetes signs like dry mouth, slow healing, frequent infections, cardiovascular risks like gum inflammation, bleeding gingiva, and they can indicate potential heart issues going on also. General health indicators like oral lesions, discolorations can be systemic issues as well, such as squamous cell carcinoma. And airway, that Mallampati score. And sometimes we take an Epworth sleepiness scale test for our patients and see if they're a good candidate for a sleep test. So given this, oral health isn't just a responsibility of dentists. Both dentists and physicians play a role in patient outcomes. And the more we collaborate and communicate, the better we can prevent and manage systemic conditions. Referrals and consultations should flow in both directions to create a holistic approach to care. So collaboration offers big benefits. Patients get more comprehensive care, chronic diseases are managed more effectively, and ultimately we see improved outcomes. For patients with complex needs, having both their dentist and physician on the same page can be life-changing. As physicians, here's how you can help bridge the gap. Encourage your patients to prioritize their oral health, especially if they're at high risk for systemic conditions. Consider oral health in your patient history, and if you notice signs that point to dental issues, refer them to a dentist. These steps can make a big difference. There are already some models of coordinated care bringing medicine and dentistry together. Some hospitals and clinics are experimenting with setups where dental and medical services work side by side. Implementing these in more areas would make it easier for both fields to track and respond to patient needs. On the research front, the link between oral and systemic health is being explored more every day. Innovations in technology and treatment are constantly emerging, and new preventive measures are on the horizon. Staying informed about these advances help us improve all of our practices. So a few cases. George was a 43-year-old male with a severe history of GERD and had a term many of us use, which is called dental phobia. A few of his teeth had fallen out on their own, and his remaining teeth were mobile. So we coordinated with George's primary care physician, got him on a proton pump inhibitor, and then eventually we restored him with implants and a prosthetic on both the upper and lower jaw. Eva was a 62-year-old patient who had some dental work done in Romania and Poland and wasn't really too happy with it. Her chief complaint was difficulty chewing and dry mouth. Her medical history was significant for diabetes, hypertension, and hypercholesterolemia. Many medications can lead to dry mouth and xerostomia, as we spoke about. And so we added some dry mouth paste and some xylitol tabs, did a deep cleaning, and we ended up doing some implants and some restorations. Jack had come in after a motorcycle accident that had taken out a number of his upper front teeth. Trauma is also another part of dental medicine that needs to be addressed. He had an ongoing maxillary sinusitis as well, and so we referred him to the ENT. We found out he had an invasive fungal sinusitis. Thankfully, it was treated. We completed some dental bridges and a deep cleaning, which is also known as scalene root planing. Joanne had come in. She was a 64-year-old patient who presented with severe wear on the mandibular dentition, was a pretty heavy smoker, had an upper bridge that was hurting, and she was also a delta bruxer, meaning like aggressive bruxer. So we had her work with her physician and a psychiatrist to help her with smoking cessation prior to any dental implants. And this time we did a zirconia restoration that could handle the bruxism. She still didn't even know how to smile by the time we were done because she had never smoked. And lastly is Elizabeth. You saw her picture earlier. She was a 29-year-old who presented with severe acute generalized periodontitis, rampant caries, and malocclusion, meaning her bite was way off. She was on antidepressants and was also on anti-anxiety meds. And we discussed treatment with her physician because she was also pregnant. So we ended up extracting all of her teeth and placing a fixed prosthetic under mild sedation. And a few months later, she had a healthy baby boy. And so this was her at the end. Here's a bunch of my references from today. And Jazakallah khairan. Thank you.
Thank you so much, Dr. Haque. For those who are listening, this session is recorded. It's going to be posted on the IMANA Education website and YouTube channel. So if you're interested in taking it another listen, as well as checking out the research studies and articles that Dr. Haque shared and wanted to scan those QR codes or didn't get a chance to, it will be up in a couple of days. But thank you so much, Dr. Haque. You definitely highlighted how important dentists and physicians need to have a symbiotic relationship. You shared a lot of cases of chronic conditions that your patients have had and that you've had to reach out to some of their physicians to work together. Now, physicians don't often have, we tend to have a very limited education in medical school and in training when it comes to oral health. And that's because there are dentists out there that's their primary focus. However, poor dental hygiene, it definitely impacts the rest of the body. You talked about periodontal disease, its increased risk of heart attack and stroke. So what are some types of things for physicians who are listening, cardiologists, endocrinologists, PCPs here? Are there particular signs that might indicate a connection, especially when we talk about referring to a dentist? Are there certain things that you would recommend physicians be aware of or know or pay attention to when they're dealing with patients with chronic diseases? What advice would you have for them?
That's a great question. I think communication is always key, right? So one of the things that would be really beneficial to the patient's outcomes is just a simple question of, hey, do you go to the dentist? You know, if they go regularly, you know that they're probably getting decent care. But one of the things importantly, like for example, if patients getting chemotherapy or radiation therapy or having any significant surgery, oftentimes we want the patient to have at least a checkup to see if there's any underlying like significant dental issues, because if there's any severe infection, the surgical outcomes or the outcomes after chemo and radiation are not going to be ideal. Um, Unfortunately, with chemo and radiation, the immune system, and this goes back to endocrine system as well, um, when a patient has a lot of infection in the mouth, right? They're not going to heal as well, especially if their immune system is weakened, right? So more so like with radiation and chemo, that region is not going to do as well if it's localized radiation. I'm doing it in the head, but if there's localized radiation, let's say for breast cancer, they're not going to be their cells, especially their salivary gland cells, are not going to be multiplying as much, and oftentimes they're going to get more dental infections afterward. And if their immune system is weakened, they're not going to heal right. So those are really important scenarios. With cardiologists, it's really important to make sure that they inform their patients, hey, make sure you don't go to the dentist for 6 months after open heart surgery. And they do. They've gotten really good about having, clear notes to the patients about what's going on after major procedures. People with congenital conditions, they almost always will come in and tell us from the get-go, yeah, my cardiologist told me I got to take antibiotics before I start. Okay, cool. Let's prescribe them before you even come in.
That's very important. Thank you so much for pointing that out. Another question I had actually had to do with, Islam talks a lot about the importance of oral hygiene. You touched on that a bit. And one of the aspects of our tradition and the Prophet, peace be upon him, is using the miswak. I was very curious what your thoughts are from a professional standpoint. This was a 2005 study. It was done that found an in vitro antimicrobial comparison between a miswak extract, and it found that a miswak can strengthen gums, it can prevent tooth decay, it can eliminate toothaches, bad breath, it can promote cleaner teeth. And so some of the researchers deemed it actually better than a toothbrush. But I'm curious,
Absolutely.
from your professional standpoint, what are your thoughts on that, especially for Muslim patients who do have chronic conditions and want to use that? What are your thoughts?
I think that's a phenomenal question. Miswak is completely bacteriostatic. It works wonderfully, but it requires the use of it regularly. Our Prophet Sallallahu Alaihi Wasallam, he had one of the Sahaba Ikram one time follow him around to see how many times a day he uses it, and that Sahaba lost count by Zohar time. So it's one of those things that if you use it, you got to use it often. You got to use it well, and it does work completely, but it also is very technique sensitive. If you notice, a miswak has the bristles in line with the actual handle of it, and I love miswak, but it's tough to use on posterior teeth, so you have to really get in there when you use it, and it actually works far superior than honestly a toothbrush does in terms of the area between our teeth. We call that the interproximal area, where our teeth butt up against each other. That area, miswak works far better than toothbrushes do. That's why we add on flossing, right? So in the quote unquote American dental world, we'll advise to our patients to brush twice a day for 2 minutes a day, 2 minutes at a time, excuse me, and we'll advise them to floss once a day. And we know that less than 20% of our patients floss daily. So now we've been trying to prescribe a water irrigator instead. So water irrigation works really well. There are these little devices. There's a number of companies that make them, but they will basically use water. We do that when we make wudu, by the way, but they use water and pressure to really clean between the teeth. But miswak, absolutely, but it requires very regular, diligent use of it.
That's really interesting. I don't think people often think about, ever using it every once in a while, or, if you go overseas and you get some fresh miswak and
Yeah.
people are all excited to use it, but it's kind of an every now and then occurrence. So using it regularly, it does offer those positive benefits.
Huge. And I will tell you specifically, there's a number of studies on miswak, on different types of miswak, meaning coming from different places. The specific miswak that comes from Medina has been proven to be the most effective in terms of like reducing bacterial load. So they are not all made equal, is what I'm trying to say.
Oh, okay. Okay. That's interesting. It's good to know as well. The last question that we had for you, and if you have any more remaining questions, please feel free to put it in the Q&A chat box or go ahead and put it in the regular chat. You mentioned fluoride. Curious what your thoughts were on that as well.
So it's a controversial topic these days, especially in the holistic spectrum. We do have a lot of patients that, ask for naturopathic kind of uh, techniques and, want to avoid amalgams, which are those mercury fillings, right? And want to avoid fluoride. And so we do have, thankfully, we have an alternative, which is xylitol. But fluoride has been used in America for, God knows, ever since the American Dental Association has been around. Uh, it is something that's added to our water here, our tap water, in at least in Chicagoland and in many areas of America. Fluoride is added to the water to help decrease cavities. Um, some folks will say that it's poison. Yes, if you take enough fluoride in at once, it is poisonous, but so is Tylenol. Um, there's a lot of things that are poisonous if you take too much of it. Um, but fluoride is, it's topically, it does prevent decay. It does reverse some young incipient decay, meaning incipient, meaning like early cavities. Um, but it does not, it does have its drawbacks, especially in a developing child, pregnant mom with a baby in utero. It does have some impact on their bone development.
Yeah, it's definitely people becoming much more aware of good health practice is a good thing. But like you said, just like anything else, moderation is key there, it seems. And
And I
it's
will tell you, children's toothpaste, a lot of them don't have any fluoride in them. And that's like mainstream, I'm talking about, have no fluoride or very little fluoride in them.
hmm,
But a great alternative, if you're worried about fluoride or nervous about fluoride, a great alternative is xylitol. It starts with an X, by the way.
okay.
Xylitol. Xylitol.
Very nice. Thank you so much. Thank you so much, Dr. Huck. We greatly appreciate you taking time and sharing your expertise. There's so much that we can talk further about regarding oral health, and there's so much that the entire medical community can benefit from hearing more. We'd love to have you back in the future if you are
Sure.
available and interested.
Anytime.
Cover a different topic. I think there was one that I really wanted. Maybe we'll have more time in the future is you talked a little bit about dental phobia and the connection between mental health and oral hygiene. I would love for us to maybe have a discussion in the future on that.
That'd
The
be huge.
self-esteem fact, that would be wonderful. So,
Yeah,
or another topic in the future. And for those who are listening, if there's a topic of interest for you that you have that Dr. Huck could cover, please let us know. Please feel free to reach out to the IMANA education community, and then we can reach out to him. But with that, we'll go ahead and end our session. Thank you again to Dr. Huck. And we look forward to next month where we will have our next education session. Jazakallah khair. Assalamu alaikum wa rahmatullah.
Alaikum assalam.